Good morning, everybody. So my name is Chris Carrigan. I've got this rather grand title of Expert Data Advisor for Use My Data. Essentially, that means I've been working in and around health data for, well, as long as I can remember, all my life, really. And I've done a fair amount of work in and around all the different aspects of health data. And a few people had said, could we do some sort of mini drop-in learning sessions about different data topics? Now, we've run a few of these before, but for a small number of people. This is the first time we've expanded it out to a much wider group, and I can see more people are still joining. So we'll see how it goes. The smaller group of people is much more interactive. I want to try and make this as interactive as possible, but we'll see how that goes. In terms of if you want to ask questions as we're going along, if you think things aren't clear, please do just shout up. The easiest way is to put your little hand up if you've got the little electronic hand on your Zoom screens. If you can't do that, then just make a noise and I'll stop. I'm fine either way. If everybody starts making noise at the same time, we'll probably have to close the microphone slightly, but I'm sure we'll be okay. But if you want to ask questions at any point, please do. If things aren't clear, please stop me and we'll try and make things as clear as we can. Okay. So we've got an hour to do. I won't spend an hour talking. The idea is I'll just go through some elements around data and inequality to give you some background generally about how data can be used to measure inequality, some of the difficulties, and then we're going to look at the ethnicity dimension of inequality data specifically, because there are some interesting insights in that, and it's a good example of what is possible and what might not be possible in some areas. So what I'm going to try and cover fairly quickly is, well, what do we mean by equality data? People talk about equality and equality data, but there's some go through some clarity about what we mean by equality. Indeed, we'll then look at what the legal requirements for measuring equality within society are and whether any of those can be measured within health data. What data is actually available? We've heard a lot that there's lots and lots of health data. The NHS has got huge amounts of data on all of us as we go through our health careers, if you like. But how much is really there, and how good is that data that's been recorded? And is it good enough to be able to use, and what happens when you do use it? And then finally, I put some pictures throughout the presentation. And when we put the slides up afterwards and make the recording available as well, you'll be able to watch the recording. And if you look at the slides, if you click through the slides from some of the pictures, it will take you through where that source of data is that I've referenced. So hopefully it should be a useful resource afterwards. And as I said, if there are things I've not covered around equality that you should be in there, please, again, shout up on that as well. We'll try and make this as interactive as possible. Okay. So let's start with the quick stuff, the legal duty. So the Equalities Act 2010 was very clear on what it thought were protected characteristics around equality. And those are listed down the left: age, sex, sexual orientation, and elsewhere. You can read down the list there. Some you might expect, some perhaps not. What I tried to do here is to look at the health data and say, well, for all of us in the healthcare system, how much of those equality characteristics are actually captured? And you'll see down on the right-hand side, to the right of the bullet points, I tried to give a rough idea of how much of those data are captured. So routinely, you're always asked for your age, your date of birth, as we know when you're in the healthcare system. So age is very common across all health data sets, as it is sex. Sexual orientation, it is recorded, but perhaps less so. Gender reassignment, generally not recorded unless you're in specialist services. Similar with disability, community services will record disability, and that's an equality dimension, but not as good within other services around routine healthcare. And you can see down as go further on down the line, marriage and civil partnership is in some admitted patient care data when you get admitted to hospital and other data sets. And the one which is highlighted at the bottom is around race. So race isn't recorded in health data sets, but ethnicity is well recorded. And that's the one I was going to look at in a bit more detail as we go through the slides. So you'll find all the dimensions down the left will be in some data sets somewhere in the NHS. But what I'm trying to point out is generally some things are recorded much more than others. Then you look at the other element of a legal duty, which is the Health and Social Care Act. That was the first time they introduced to the NHS some specific legal duties around health equalities and duties on the Secretary of State, which means if you're going to monitor these things routinely, robustly, you need to be able to define what they are, you need to be record the data properly, and then you need to be able to analyze that data properly. If you're not recording data about something, it's impossible to count. And if you can't count it, it's impossible to look at variation across the country. It's pretty simple, really. And then there's a third element which I pulled in, which is what I call the practical duty. So throughout a lot of the work that gets done, particularly around government, the big national agencies particularly, this thing called inequality impact assessment. So it's like a risk assessment if you're taking some school kids out on a trip. It's like a data protection assessment if you're trying to use data. An equality impact assessment says if you're going to analyze data which is there, if you can do some research, do some analysis, then actually what you should be doing is looking at all the different equality dimensions and asking the question, is it possible to do my piece of work and also do it by ethnicity, or do it by age, or do it by sex? So the equality impact assessment is a mechanism that lets you, at the start of your piece of analytical work, say how much of the equality dimensions could I actually include in my results. And I think that's generally good practice. We're seeing more and more of that now. And in fact, the link put on the bottom was to the most recent cancer strategy, which includes the provision, the requirement to say, here's an equality impact assessment around how the strategy was written, which includes an element of data in there as well. Oh, I thought it was a question. So there are other dimensions of equality, not just around the Equality Act on the legal side. There's a few here. Deprivation. Deprivation is a big area of inequality. We know that, the rich versus poor, the north versus south. There are other ones as well. Geography, education, language. So the quotes underneath are just simple ones I pulled out from existing reports, existing articles about the impact of deprivation as an equality measure on society. You can see there are some clear differences between rich versus poor in deprivation. Anybody who's worked in health data will recognize that. Other areas around geography. So you could say, does living in a rural area, do people living in a rural area get better health care, better health outcomes, better experience than others? And again, that information is available. There are lots of reports around that. The last two, education and language. So education and language, well, education specifically, isn't recorded well within health data. And there is a push to say, if you could link national health data with national education data, you could begin to derive a lot more learning from that. So for instance, you could say for children and young people who are diagnosed with a disease in their early life, what effect does it have on their educational attainment levels and indeed their career pathways afterwards? Some of that you can do with small studies, but with large health data, there's a lot you could learn from that. And what you'll see, I think, over the next few months from the policymakers is a real push to try and bring some of those data sets together. And that's an area we need to think carefully about, and what we want to derive from it and what the benefits might be and what the controls are, and what say we have in all those things. And finally, the point about language, there are some studies which clearly show people who can't speak English are much less likely to have good health. So there are all sorts of different dimensions of equality, not just the ones that are in the law. And there may be others that you think about that you want to raise as we go through. So for each one of those things, you could do a whole raft of talks about what data is available, where it sits, how good is it, and what's been done with it. I'm going to pick one of those, which is ethnicity, one I flagged at the start. So this is going to be a walkthrough, just looking at ethnicity data, about how it's recorded, where it's recorded, and what gets done with it, and some of the difficulties. Just using ethnicity as an example. So first of all, this is a screenshot of the NHS data dictionary. It's slightly different if you looked in different parts of the UK. This is the England version, but the emphasis is much the same. So if you're going to record ethnicity in the healthcare setting, you need to define what you mean by it. So there are all these, the work that goes on behind the scenes to define coding systems for ethnicity. For instance, for ethnicity itself, it actually uses exactly the same coding structures as is in the UK census. So the UK census returns, we all complete every 10 years normally, includes questions to us about ourselves, our families, our status, and it includes ethnicity. So those ethnicity codes that are used in the census that we all complete are also used across the healthcare systems, which allows you to do some comparisons and some matchups with those things. So these data definitions are not just made up, they tend to use the ones which are normally available in other settings across the UK. These are those codes. So you may remember them from when you filled in the census. You may also remember them if you filled in a form to do with your healthcare or when you registered with a GP. These are sort of questions you'd be asked. Now, those have been through, for instance, some clinical trials. You might get asked some more detailed information on this, but these are the national ethnicity breakdown categories that are used across the NHS. That means where data has been recorded about your ethnicity, everybody across the healthcare system uses the same codes. Indeed, for these, all these same codes are also used in the census data as well. So it's quite a robust way of recording, of defining the data and recording things consistently. And when you do that, you can produce a whole set of data at the population level. So this is just one example I pulled from Wales. And if I hover over it, you'll see when you see the slides afterwards that you can click on that and it'll take you through to the report. So you don't need to make a note of that here. You can click through later when you get a copy of the slides. So this is one thing you could do, which is look at the population. How does the population look in terms of its ethnic structure? And how much of that ethnic, if you use the ethnicity data within the country's health data, do you find variation in health activities, experience, and outcomes? This was just for Wales. And when you dig beneath reports such as that, you begin to see data such as this. So this is from England. I'm trying to move around the UK as best I can. And again, if you clicked on this when you see the slides, it will click you through to the actual reports. These are all freely available published data. And this is looking at subnational level. So this is looking at the England column towards the left, and then you've got various numbers around different parts of the East Midlands region. This is one part of England. And down the left-hand side, there's a whole set of dimensions to do with ethnicity. So it just begins to show that the amount of information which is available about us, about the population, about our care and our treatments, subdivided by ethnicity, there's a fair amount out there. What I would point out, though, is that lots of the ethnicity coding isn't well recorded. So the top line on here, the records with valid ethnicity code, that's a fairly old period of time. Actually, there's probably a newer period now. But you'll see not every record has an ethnicity code recorded. And if you look across the top, if the average for England is 86.1% recorded, it varies in the first two columns. Derby 94, Derbyshire, the wider Derbyshire 77. So the percentage of records about us which have the ethnicity coded in there varies quite a lot. And that's just in one small part of the country. So go back a step. Let's think about when ethnicity data is recorded about us. And we're talking about ethnicity data here, but by and large, lots of other data is the same, mechanisms. So when you register with your GP, your ethnicity gets recorded on your GP record. If you've registered with a GP recently, there's a whole set of forms you fill in about you and your family history and your health and various other aspects about you, but you also include your ethnicity. It's also on your hospital record. Each time you go into hospital, the ethnicity data is recorded against all the different hospital activity data as we go through different hospital settings. So you'll see there, including maternity and birth. I put an asterisk against the GP because that's, as you might have clued up, that's my next slide. So when you do record with your GP, not everybody records ethnicity. Now, I don't know whether that's because the individuals themselves choose not to, or whether the GP doesn't ask, or whether they're not sure. But certainly when you look at the recording of ethnicity within primary care records, GP records, well, you can see the quotation on there, it's not complete. There's still some way to go. So even though the NHS has defined a standard coding system for ethnicity, and even though it's mandated it in its data sets to be recorded, A lot of the time, it remains empty, and that can cause problems further on down the line. If you look at GP records, each one of those blue horizontal vertical bars is a practice. And the higher up the chart you get, the more of that GP records have got ethnicity coded within them. I think this was a couple of years old, but it really demonstrates that across the country, you'll see huge variation in the coding of ethnicity within GP practices. Some are very low, some are going quite high. But this is where you get the problems in interpreting some of the statistics you'll see on the screen, on the TV, whether it's about COVID or whether it's about diagnosis or poor experience. The real problem you've got with looking at ethnicity, or indeed lots of the other equality dimensions, is the data isn't just poorly recorded, it's inconsistently recorded across the country. And that makes results sometimes difficult to interpret. And this is one of the downsides of poor basic data quality, data not getting recorded in the system. So that was GP systems, a wide variety. If you then look at your hospital data, and you're looking at the A&E, outpatients, inpatients, hospital admissions, and some other treatments, you can do the same thing. You can look at how much of those data how much of those records get recorded with ethnicity data. And again, I've gone back up the north to Scotland for this one. So I hope the colours are coming through. But essentially what you can see is the higher up that chart, and the bottom scale is over time, 2018 out to 2020. The higher up the chart you are, the more your records in a hospital setting include ethnicity coding. And again, you'll see at a hospital level, there are different, so this is a health board level, you'll see huge differences in the amount of data which is recorded. Now that's nothing to do with technology, I don't think. It's really just sort of implementation, policy and practice within a local setting. And that's where, if we as individuals are interested in helping the NHS monitor inequalities by, in this case, ethnicity, maybe we do have a voice to go to our local health board or go to our local GP groups or go to our local hospital patient groups and say, can you show us something about the basic data recording that you've got within this organization? Because we need to understand the healthcare that we receive as a community. So there's a huge variety of recording across different health settings. Come back south of the border now, looking back in England, and this is looking at a lower level. So in England here, this is looking at the amount of the error rates in ethnicity data recording across different parts of Northern England. And you'll see, again, a wide variety. If you look at the bottom two, relatively close places, the error rates overall for admitted patient care, that's APC, this is inpatients, outpatients, A&E. The amount of missing data in there is significantly higher in one part of Southwest than the other parts. Now, the people are not any different, the services are not different, the treatment's not different, it just tends to be local practice means the data isn't being recorded for some reason. But by looking at these figures and publishing them, you could begin to ask the question, why is that the case? And hopefully try and do something about it. And again, that's one of the key points, the importance of publishing these data rather than just recording them and ignoring them. If you look down even further, this is picking up one of those areas, and it looks at individual hospitals, individual trusts within that patch. And again, you don't need to look at the numbers other than you'll see some significant differences in the way things get recorded. So even across relatively small, let me pick that one, relatively small parts of the country, you'll see significant differences in organizations which are quite close to each other, significant differences. And this is just the basic data recording. I'll try and get rid of my pen now. There we go. So this is what the data lets you do. You can now begin to see where the data is recorded or isn't recorded. And I think what we have to do is recognize that if data is not available, you can't be counted. It's very difficult to prove there are differences in experience or care if the data is not available. So that's part of our job. If you look at another dimension, which is Genomics England, which is a subset, quite a specialist subset, 100,000 patients in Genomics England. It's known to be a very high quality data set, which is used for lots of research, but even in there, their reported ethnicity is around 77% of cases. A quarter of cases are missing ethnicity codes. Now that's pretty consistent across the country. But even for them, what you'll see is At the first line, if you look at in Genomics England, there are 3.67 patients recorded as Asian or Asian British, whereas if you look at the population, it's much higher. That lets you begin to ask the questions, is that because we've got a lower representation of Asian or Asian British people in Genomics England study, or is it that there's less recording, the data is less complete for those people, and therefore we're not able to include them in the studies when you're doing the evaluations? So there's lots of things around the problems you get with low quality, poor quality, and missing data, ethnicity in this case. And what you see is where you get variation, that introduces caution about some of the results you can interpret. So what does the data actually tell you? Again, I've looked at ethnicity, and this is a slide from, I think, Cancer Research UK I got, because they do some very good statistics on this. But when you're able to use the data, you're able to draw some quite large scale conclusions. So even though perhaps a quarter of the data might be missing for ethnicity coding, if you look at a population level, you can still draw some conclusions because you can build in statistical robustness in there. In this case, a couple there for males and females, just in terms of cancer. If you stick with the cancer theme and then you look down at a particular cancer, in this case, breast cancer, if you've got the data recorded, then what you're able to do is look at a few different things. Now, don't worry about interpreting the graph, but what it shows you is the bottom shows you the different ethnic groups, and the three columns are how early or late somebody's been diagnosed with a particular cancer, in this case, breast cancer. The point to note is there are differences. There are differences across the ethnic groups in how early somebody's detected with cancer, or indeed how late they're detected with cancer. And as with all disease, if you detect cancer at a later stage, your outcomes are much less good. So this has a direct impact on people. And without the data, you'd never be able to draw these conclusions. And without using these data, you'd never be able to make any improvements. So this is where the data really becomes helpful. You'll notice, I don't know if you can see where my mouse is, on the right-hand side where it's got this early, there's a black line there. That's called the confidence interval. So when the data gets quite small, you have to be careful about how you interpret it, because there could be some noise in the data. So when you see bars like that on the line, it's called the confidence interval. And the answer is basically saying, rather than where the blue line stops, the answer is somewhere between the top of the black and the bottom of the black lines. But you can still see there are differences by ethnicity in this area. This again is drilling that cancer data down even further. This is looking at what they call emergency presentations. So if you arrive at a diagnosis but as an emergency, you tend to do much less well. It's a non-managed diagnostic route. If you go through screening or you'd have your routine test with your GP, they can pick things up early. If you arrive in A&E, it's likely something seriously wrong, and your outcomes are much less, whatever the disease. In this case, it's different sorts of cancer. And what you'll see again is differences by ethnic group in the way people arrive at a diagnosis. And that directly affects their health outcomes. And again, you'll be able to click through that and look at the full report if you want. The other question gets asked a lot is there variation by treatment for different ethnic groups? Now, I have to caveat this. This one is quite an old slide, and I've miserably failed you by trying to pick up a more recent slide, but it must have been available. And if I can find it, I'll slot it into the slides as we go through, before we publish them on the website for you. But again, because you've got the data there, you can look at what variation is by treatment in terms of the volume of treatment given and the types of treatment given. So beneath this graph, there's a whole heap of information about the different treatment types that are given, in this case, again, for breast cancer, by different ethnic groups. Now, some of those might be justifiable, some may not be, we don't know, but that's where, I don't know, that's where the data becomes really useful. Without that health data, you're a bit stuck. And bear in mind that all these figures have got 25% empty in there, so you've got to be careful about how you interpret the figures, hence the confidence intervals. If we found that all the missing 25% were Pakistani ethnicity, that would change the figures significantly. So that's where statistical adjustments come in. And it also affects not just your treatment, but you can also stratify it by survival. In this case, again, this is colorectal cancer. And this is looking at the differences in 1 year and 3 year survival by different ethnic groups. So you can see you get a difference between the different ethnic groups in terms of survival. So from the diagnostic points through the treatment points, through the survival points, you can tell if there are differences in care, particular to different ethnic groups. And as I said, all these are click-throughs. You can look at reports afterwards if you're interested in this area. If you're interested in a different disease area, cardiovascular disease and other things, you can actually follow the same path and look at different ethnic groups by those disease types. And finally, I want to mention was, I mentioned a couple of times, experience. So how do people's experiences of healthcare vary by their ethnicity? And this was to do with the National Cancer Patient Experience Survey, but there are other surveys around which you can do as well. And it allows you to look at people's relative experience by their ethnic group. And what it also lets you do is to look at, do people from non-white ethnic backgrounds actually fill the forms in the first place, or do they just feel so disenfranchised? Are they not approached? Are they not language sensitive to people? So there could be a whole reasons why there are lower numbers of people in different ethnic groups actually filling the forms in. But once they've filled them in, you can also do the analysis to find out whether they feel better or worse in terms of their overall experience. And again, there's lots published on that as well. This was one of those from that survey, which looks at overall rating of their care, in this case for cancer, can't tell which cancer, I don't think, across the different ethnic groups, and there are differences. That lets NHS trusts look at why those differences are. You also see differences across different trusts. And if you're seeing differences across the different NHS trusts in terms of patients' experience, the question is, well, what's going on in one trust which is not going on in another trust? So you can look at variation. Clearly, I can't go too far without mentioning COVID. I'm just pausing then to look at the chat, see if anybody's put something in the chat. I'll pick those chat things up in a second. So COVID is an interesting one. So throughout the pandemic, you'll have seen lots and lots of information on your screens every night at one stage around numbers and stats and trends and things going up. Now, all those things were driven by boring old data. At the start of the pandemic, it was realized fairly quickly that whilst lots of data existed, a lot of it was not linked together. So different parts of our healthcare, as many of you will have experienced when you go to your GP or your hospital and they don't have each other's information, but different parts of your healthcare data were still in different places. And the pandemic response changed things significantly. Now, one of the problems that we've had for a long time is being able to link data because of information governance concerns. So why should data about you in one place be linked to data about you in another place without you knowing about it? And that's a reasonable question. And researchers get around that by putting in ethically approved applications. They go to various approvals groups to say, my research question is this, and I need certain information from here and certain from here. And they have to jump through a lot of hoops to be able to do that research. Now, when COVID came on, the public impact was huge and was going to have a significant effect on the country. And what happened was there were some new regulations enacted, called COPI, Control of Patient Information regulations. They've been there for a long time, but never really been used that effectively. And what happened was the government issued these regulations, the notices for COPI, that said, for our response to the pandemic, we must link this health data, and we must use this health data to monitor the pandemic, to look for variation, and to learn who was being most affected, what treatments were working. Now, without those COPI regulations, lots of the benefits we've seen during the pandemic around understanding of COVID would not have happened. It revolutionized. I've been working in data for 30 odd years. I've never seen such a significant sea change of ability to link and utilize health data ever in response to COVID. Now, those COPI regulations are time limited, so they're dependent on managing the pandemic, and when the pandemic, I'll use inverted commas, goes away, when the need is reduced, the theory was those COPI regulations would be withdrawn and we go back to the normal. And what people have seen is, because of the COPI regulations, we're able to join much more data, learn much more, in this case about COVID. And the question was, well, why can we not do that with cardiovascular disease or diabetes or cystic fibrosis or cancer? And those are reasonable questions. So at the minute, the government and the various policymakers are looking at exactly that question. What we were able to do within COVID by linking data and producing vaccines really quickly, by producing other information really quickly about impact of COVID on ethnicity. Why can we do that? Not do that for routine healthcare? So those are things you begin to see in the press and the media in the coming months. And if you're on you should all be on the Use My Data newsletter. We'll try and keep you updated with those things as we go along. But that's fairly significant. Because the data was linked for COVID, and because that included ethnicity data, you could do lots more information, lots more analyses of the impact of COVID-19 on different ethnic groups. And you may remember back probably about a year ago, there was a big report published eventually, which was slow to come out, which began to break down the impacts of COVID on the different ethnic groups. You'll also notice that this one I mentioned here was called Open Safely. It's a trusted research environment where all the data was brought together and linked. Again, they've said the same thing, 26%, a quarter of the health records didn't have ethnic category. And that severely limited the amount of learning you could make at the early stages of the COVID pandemic. That was why there's a huge amount of work had to be done to understand and to make sure that the stats that came out were robust and could be trusted, rather than just too skewed by the data not being there in a quarter of cases. So this is how boring old data quality, bothering to enter somebody's ethnicity code, had a direct impact on the country in the COVID pandemic. So the real world example there. Indeed, when they managed to do the reports, we saw, you've seen these things in the press and the media over the past year or so, there were some significant differences in the way different ethnic groups were affected by COVID-19. Again, you don't need to look at the charts. When you see the slides afterwards, if you click on each one of the charts, obviously there, it takes you through to where these data are published. You can read the report yourselves. This is just to demonstrate that if the data is there, you can do a lot with it. But if the data isn't there, it begins to hold things up. So I think that was really a very quick run through of equality data, and then looking at ethnicity as one element of equality data. There are lots of dimensions of equality, not just the ones I mentioned. In many cases, the data does exist, but a lot of it may be empty. So the data fields might exist, but they may be empty. And even when the fields are there, some of the data sets are not linked together, and that makes things particularly difficult. There are lots of published analyses. I've shown you some there on the screen. There'll be other ones as well if you do Google search around equality dimensions in diagnosis and in care, in outcomes and experience across a whole range of health conditions. As I mentioned, the COVID data regulations allowed much more to happen. And I think that's something we should all keep a very close eye on in the next few months. The regulations, which were much more permissive to allow the data to be shared to respond to the COVID pandemic, there's an argument that if we could do that across all of healthcare data, we could make much more insights, frankly, save more people's lives. There's a lot in that, but equally, we need to be quite careful about how those links take place, what say we all have about that, and how transparent those things are. And my bottom point, which I've said to everybody who's ever worked with me, is whenever we're doing a piece of analytical work, a piece of research work, which uses the data, we have to think, why can we not do these results also using different equality dimensions? So rather than just limiting it to age or by deprivation, which are quite common, why can we not include ethnicity? Why can we not include any of the other equality dimensions?